Okay, thank you, Mel, very much for the kind introduction, and to Jennifer Chandler for the honor and pleasure of presenting today on a topic that I've been thinking about a lot over the past few years, which is donor research and recipient consent. And I'll just start with some disclosures that I do receive some personal funding from the Trillium Gift of Life Network of Ontario. And related to some of the slides today, some research funding from the Canadian Institutes of Health Research and the Canadian Donation and Transplant Research Program with sponsorship from Astellas. So before we start, I just wanted to remind people about the aims for research that is undertaken in organ donors. And generally, studies in organ donors, and specifically about how we manage organ donors, are undertaken to improve the number of organs that will be healthy enough to recover and transplant from each donor, to improve the function of those organs once transplanted to recipients. And down the road, we hope that these interventions will also improve the survival and the quality of life for transplant recipients. And this little figure to the right reminds us that one organ donor can save up to 8 lives through donation and transplantation. And so just enhancing the number of organs is key, but all of these outcomes are important aims for research in organ donors. So what do I mean about interventions? The experimental interventions that we talk about in deceased organ donation are really anything that we might study to enhance our care of deceased organ donors. So as an example, we might compare 2 doses of a usual treatment in a randomized clinical trial. And for instance, heparin, we administer intravenous heparin in donation associated with a circulatory death. And in fact, the Western provinces administer quite a low dose of intravenous heparin, but here in the Eastern provinces, we administer a relatively much higher dose of intravenous heparin. So these are both part of standard practice. And so you could imagine a clinical trial or an experiment where we would compare the 2 doses of this usual treatment. That would be a low-risk study. Another low-risk study would be testing a known treatment more broadly in a more broad situation. So recent research has shown us if we treat organ donors at a low body temperature, like 34 to 35 degrees Celsius, this is likely to improve kidney function in the post-transplant period in recipients for kidney recipients. But the question is, how does this affect other organs? Does hypothermia improve other organs? No effect, cause harm? We do have quite a bit of data from the original studies because our kidney donors also donate other organs. And so the original study did look at other organ recipients, but the emphasis was on kidney recipients. So the same group now in the States is undertaking another clinical trial at the moment where they're testing hypothermia as an intervention, and they'll collect a lot of data so we can really understand the effects on other transplant recipients. That's another pretty low risk study because we have a pretty good sense that there's not a harmful effect. Another intervention would be when we're testing a treatment that we really have no sense that there's going to be any harmful ramifications for the transplant recipients. And here's a case in point. Some of you will be familiar with the notion of mechanically ventilating patients in the COVID pandemic in the prone position, that is on their stomach, because that helps us to protect the lungs, to inflate the lungs, to get better oxygenation, and they heal more quickly. And so in some centers, this prone ventilation is being utilized for deceased organ donors, but it really needs to be subjected to randomized clinical trial. We can't think of how that might hurt waitlisted patients or transplant recipients in any way, but there are plausible mechanisms whereby this could cause harm. So for instance, if donors are very hemodynamically unstable and we're flipping them front and back twice a day, then they might become more unstable, and that could impair the health of some of their organs. So it really would be reasonable to test this in an experiment. And then lastly, perhaps a more high risk situation would be if we tested a really novel drug, perhaps something that's never even been used in clinical practice, any clinical practice. And we test administering this drug to deceased organ donors to assess for effects on transplant recipients with respect to their graft function in the short term or the long term. That would be, if the drug had never been tested in a clinical practice, a higher risk study, to be sure. So those are some examples of experimental interventions. So when we think of soliciting consent from transplant recipients to participate in this research, the ideal would be a voluntary, fully informed research consent process. And I say process because it's not just a one-off discussion, ideally. It would start in the pre-transplant clinic. There'd be a full discussion of a waitlisted patient with a person who's very knowledgeable about that patient, the transplant, and the research. They'd go through a classic research consent form. It might be 7 pages long, all the details, and the patient might make a decision or not and would leave the clinic with a brochure about the study. And then at subsequent clinic visits, they could rediscuss, reaffirm their decision, or make a new decision. And even when they're called from an organ donation organization that's offering them an organ for transplantation, they could reaffirm their consent to participate or not participate in the study. Then a few hours later, they arrive at the hospital to be further assessed for this potential transplant. They could re-sign the consent form. And then after the transplant, while still in hospital, they could have a face-to-face discussion with a research personnel about the study, reminding them about the study, their research roles, and then they leave the hospital with a nice study brochure that speaks to them at their level about the study. So that would be the ideal for every single study that we may undertake in donors assessing outcomes in recipients. So I'd like to present to you a case study of a clinical trial that is underway now. We haven't started enrollment yet, but the work is definitely underway. And that's the Synergy pilot trial, which is led by Dr. Frederic Daragon, who hails from Quebec. And the rationale for this study is that there's emerging data, lots of emerging data that supports pre-treating neurologically deceased organ donors with tacrolimus, which is a very common medication in transplant medicine. It prevents organ or transplant rejection, but it hasn't been administered to deceased donors. It's administered to the recipients. And we postulate that administering it to deceased donors will improve function after transplantation. So the experimental intervention is intravenous tacrolimus, which is administered just before the donor is taken to the operating room to recover the organs for transplantation. And the control intervention in this study is a placebo, so it's a randomized trial. And we're undertaking this study in 7 intensive care units in Ontario and Quebec. Just 7 because it's a pilot study before we take it more nationally. But because these organs from donors in these 7 ICUs may go anywhere in the 2 provinces and theoretically even beyond, that means that all 28 adult transplant programs in Ontario and Quebec ideally will be participating in this study. And that has implications for the recipient consent, as you'll see. The participants will be 90 neurologically deceased organ donors in these 7 ICUs, and then 300 or more organ recipients at all of the adult transplant programs across the 2 provinces. And the outcomes of interest are looking at the effect of this donor tacrolimus on recipient transplant function in the early postoperative period and also at 1 year. And our goal is to administer a medication that is going to improve transplant function right after transplantation occurs and also as far out as 1 year. So we first thought about consenting the transplant recipients or the waitlisted patients in the pre-transplant clinic. But it quickly became apparent, especially speaking with our transplant colleagues, that this may not be feasible because if you think about it, we would have to educate and train research staff and transplant staff at all 28 transplant centers, and have them take the time for this education and take the time to discuss the study with every single waitlisted patient. So that's a lot of time investment and training investment, potentially information overload if every waitlisted patient hears about every potential study that might be coming. And at the end of the day, because we're only doing this for the donors in 7 hospitals, so many of waitlisted patients across these 2 provinces will never be considered for this study. So it would be a very resource intense approach to the consent that is really, that we consider infeasible, and we have persuaded research ethics boards in both provinces that this is not a feasible approach, particularly for a low risk intervention. Okay, so then we thought, well, should we approach them at the time that they're offered an organ at organ allocation? But again, there's a feasibility issue at the time that they're called and offered an organ. They're receiving so much information about the transplant, about themselves, their suitability, and is it a good match, that it might not be feasible. But there's also the additional risk of coercion, because really in that moment, some waitlisted patients who are about to be transplanted do not have the capacity for a truly voluntary informed research consent. Some of them are physically incapable if they're encephalopathic from advanced liver or kidney disease. And some of them are emotionally incapable if they're so euphoric about this offer of a transplant that they're just going to agree to anything. And we don't want to take advantage of a situation like that. Some of them have feelings of guilt about the deceased organ donor, a sense of indebtedness to the families of these organ donors and to the health system. And so they, even if they would normally feel very uncomfortable about participating in research, time is of the essence, they have to make a quick decision. And so there is a risk of coercion. So that's not a great time either for this particular study. So what are we doing? So we're taking a staged approach to the recipient consent. The first stage is merely a clinical consent to receive an organ from a synergy donor. So the waitlisted patient says, yes, I'll take a synergy donor organ, or they may say no, in which case they still get the organ, but the donor won't be randomized to the study. The second stage is the research consent. And that's where there's a discussion about, can we use your data, the recipient data from health records in the synergy study analysis? So I'll show you in more detail how this works. So you can forget about the green bars at the top. That's for when I'm discussing the donor consent process, which is equally important and almost equally complicated. And we'll focus on the lower half of this slide. And these orange stars remind me to tell you about where the recipients and waitlisted patients are receiving information about the study. And it starts way before organ allocation. They may see a poster about the study in the transplant clinic, and they may not see it, but there's going to be posters, and I may register with them. Oh, there's a study going on. Oh, that looks like I might be interested in it, or I wouldn't be interested. And they may remember that. But then at the time of organ allocation is the stage 1, the clinical consent to receive just an organ from a study donor. So a transplant coordinator or a transplant physician calls this waitlisted patient and says, okay, we have an organ, we think it's going to be suitable for you. And in that telephone conversation, they always impart a little bit of information about the donor, and they would mention the synergy study in a way that we will have scripted out, authorized by research ethics boards, so that it's very simple for them to understand. And they might, in that moment, in that phone call, say, "Oh yeah, sure, go ahead. I'll take a study organ," or they may say, "No, I don't want a study organ," in which case the donor won't be randomized, or they may say, "I'd just like to wait until we get into the hospital and discuss further." So in a few hours, they're in the hospital. It's still prior to transplant. It's still usually long before the organs are recovered from the donors in the donor hospital. And then they'll sit down with the physician. They'll receive another an information sheet about the study, very simple phraseology, and have this discussion again and decide whether or not they'll receive an organ from a study donor. And if they do, then the next stage, as you can see here, is moving on to the transplantation. And then post-transplant is when we move to stage 2, and that's the research consent. So research staff and probably a donation coordinator in collaboration with the research staff will go to the bedside and speak to the transplant recipient if they're capable of a discussion of this nature at that time. They'll remind them that they received an organ that was from a donor who participated in research. And then they'll go through the research consent form and decide with the transplant recipient whether or not they would choose to participate in the research, meaning allowing their data from the hospital records to be utilized in the study database and study analysis. And occasionally, hopefully rarely, that discussion could not occur while they're still in hospital, and we do have authorization for a deferred consent for that research participation over the telephone. Okay, so that's how we're planning to do it in the Synergy pilot trial. But clearly, one size does not fit all, and we're going to have to customize the approach depending on the timing of the donor intervention, depending on the risk to transplant recipients. And also, I anticipate that our approaches will evolve over time as we gain more experience in Canada of donor intervention research that involves the transplant recipients. And as we learn more about how patients would like us to operationalize the recipient consent. And that takes me to my last slide, which is about advancing our knowledge on patient values around recipient consent. So these are pictures of 2 PhD students who are working under my supervision at McMaster University. The first is Amanda Lucas, and Amanda is a critical care nurse who, as part of her PhD, is interviewing transplant recipients and very effectively soliciting their views and perspectives about their research consent. And she's now collating all of that information. That the interviews are recorded and transcribed and analyzed, and we're putting that into a manuscript right now. And then Kinia Honormund is a critical care physician, also undertaking a PhD, and she's taking this research to another level. And what she plans to do is to conduct similar interviews, but involving waitlisted patients, donor families, transplant clinicians, members of ethics panels similar to those participating in this conference over these 2 days, so that we can really better understand patient values and fine-tune our methods so that we're really using approaches that seem to fit with the values of the people most important to the research. So with that said, I think I'll wrap up right here, and thank you very much for your attention.
Thank you so much, Maureen, for this great presentation, and I'm sure we're going to have a lot to discuss at the end of the session. I have the pleasure to co-moderate the session with Dr. Laurie West, the Scientific Director of the Canadian Donation and Transplant Research Program, and I'll let Laurie introduce the next speaker.
Thanks very much, Mel, and thanks, Maureen. That was really interesting and shows us the complexities, additional complexities involved. So our next speaker this morning is going to be Charles Weijer. And Charles, I hope I pronounced that correctly. Charles is at Western University, where he, for many years, was held the CRC, the Canadian Research Chair in Bioethics, and has clearly done a lot of work in complex medical issues and the bioethics associated with those. And we're going to hear from him today on the ethics of non-therapeutic research on imminently dying patients. Thanks very much. You can go ahead, please.
Well, thank you. Thank you for that kind introduction, and thanks very much to Jen and the rest of the organizers for the opportunity to share some of the research ethics work from the New Part study led by Tennille Gofton and Murat Slezerov. The project I'm going to describe was led by postdoctoral fellow Nick Murphy and involves Derek Dubicki, Jeff LaForge, Loretta Norton, Tennille Gofton, Murat Slezerov, and me. The ethics of research in palliative care, in which patients have days or weeks to live, was debated and largely resolved 2 decades ago. Fueled by questions relevant to organ donation after circulatory determination of death, researchers are now interested in conducting research on patients just prior to and after the withdrawal of life support in the intensive care unit. So we ask, is it ethical to conduct non-therapeutic research on imminently dying patients? And if so, under what conditions? In my talk, I will briefly describe the New Part study. I will outline an ethical framework for research involving imminently dying patients, and I'll discuss how the framework applies to the New Part study. So let's begin with a description of the New Part study. There are 2 different circumstances in which organ donation after death occurs. Broadly, deceased organ donation may follow brain death, or it may follow circulatory death. For each, the process for the determination of death differs. Further, these processes have different implications for the viability of organs for transplant. So let's discuss each, beginning with organ donation after brain death. In brain death cases, death determination involves confirming irreversible cessation of brain function using clinical criteria that include a neurological clinical exam and, when required, additional neurophysiological tests. The continuation of circulatory and respiratory support throughout the neurological determination of death process helps ensure that organs for transplant are well perfused and protected from damage. However, given that brain death is rare, the original method of deceased donation, that is, donation after circulatory death, was reintroduced to address the organ shortage. In circulatory death cases, patients with poor prognosis who are not brain dead and consent to organ donation undergo planned withdrawal of life-sustaining measures and progress to circulatory arrest. Death determination occurs following a 5-minute hands-off period to confirm that cessation of circulation is permanent. An important difference with brain death cases is that circulatory and respiratory support is withdrawn in these cases, and that means that organ perfusion and oxygenation is interrupted during the dying process and hands-off period. Organs for donation suffer ischemic injury as a result, and this can lead to worse outcomes in recipients. In further contrast to brain death cases, the cessation of brain function is assumed but not explicitly confirmed to occur at the same time or shortly after circulatory arrest. This presents 2 conflicting challenges. On the one hand, if brain function persists beyond circulatory determination of death, there's the potential for donor harm. And on the other hand, if cessation of brain function precedes circulatory determination of death, then determination of death may be unnecessarily delayed, leading to organ damage and worse outcomes post-transplantation. So the new part study seeks to determine when does brain function cease relative to circulatory arrest after withdrawal of life-sustaining measures in the intensive care unit. Establishing the temporal relationship between circulatory and brain arrest will do a number of things. It will inform the appropriate timing for death determination in circulatory determination of death. It will protect donors from harm, and it may enhance donor organ viability. The new part study will enroll adult patients in intensive care units for whom a decision has been made to withdraw life-sustaining measures. Patients may or may not plan to donate organs. Data will be collected on circulatory and neurological activity and function for 30 minutes prior to withdrawal of life-sustaining measures, throughout the dying process, and for up to 30 minutes after the circulatory arrest. Data will be collected from monitors already in place, as well as monitors added for research purposes. Circulatory monitoring will record cardiac electrical activity, pulse pressure, and blood oxygen saturation, and these monitors will already be in place. Neurological monitoring will record cortical electrical activity, cerebral blood flow, cortical function, and brainstem function. And all neurological monitoring will be added solely for research purposes. It should be noted that no patient will have more than 2 neurological monitors. So let's talk now about the ethical framework. Imminently dying patients in the intensive care unit are vulnerable, meaning that they're at an identifiably increased likelihood of incurring additional or greater wrong. Imminently dying patients are liable to autonomy wrongs because they're unconscious and are not able to make decisions regarding research participation. Welfare wrongs occur if research interferes with end-of-life care or intrudes into a family's last moments with the patient. And justice wrongs occur when imminently dying patients are exploited. The vulnerability of imminently dying patients, coupled with social discomfort with death and dying, leads some people to believe that such research should not be conducted. But in research ethics, vulnerability is not a reason to exclude people from research. Rather, vulnerability requires additional protections for participants. Protections derived from general ethical principles for research as defined in the Belmont Report. Specific protections for incapable adults in research have been articulated in a variety of ethical documents. Finally, recent scholarship highlights the need to ensure protections for bystanders in research. That is, people who are not research participants, but who are nonetheless impacted by research. These precepts led us to 8 ethical questions that ought to be addressed by researchers and research ethics committees when research involves imminently dying patients. And the questions are, does the study hypothesis require the inclusion of imminently dying patients? Are non-therapeutic risks and burdens minimized consistent with sound scientific design? Are the risks of these procedures no more than minimal risk? Are these non-therapeutic risks justified insofar as they are reasonable in relation to the anticipated benefits of the study? Will valid informed consent be obtained from surrogates? How will incidental findings be handled? What additional steps are in place to protect families of research participants? And what additional steps are in place to protect clinical staff and researchers? So let me now describe the application of this framework to the new part study. For the sake of time, I'll only briefly discuss 3 issues. So let's begin with research risks. Our ethical framework asks, are non-therapeutic risks and burdens minimized, consistent with sound scientific design? And are the risks of these procedures no more than minimal risk, That is, the risks of daily life of the study population. Participants in the NEWPART study will have both circulatory and neurological monitoring. Recall that circulatory monitoring will already be in place as part of routine clinical care. Thus, while data will be collected from electrocardiogram, an arterial line, and an oxygen saturation monitor, there are no research risks from lead placement or the insertion of an arterial line. The different types of neurological monitoring are non-therapeutic research procedures. To minimize risks, NEWPART participants will undergo no more than 2 of 4 possible neuromonitoring procedures. The placement of EEG leads and transcranial Doppler is not associated with any pain or discomfort in conscious adults, and we believe they pose only minimal risk to participants. 2 of the neuromonitoring techniques are, however, potentially burdensome. Somatosensory evoked potentials involve repeated electrical stimuli to the wrist that in conscious adults may be experienced as annoying or unpleasant. Brainstem auditory evoked potentials involve an auditory stimulus like a hearing test where volume ranges from a whisper all the way to a yell. NEWPART participants will be limited to at most one of these 2 non-therapeutic procedures. While somatosensory evoked potentials and brainstem auditory evoked potentials may be experienced by conscious adults as unpleasant, remember that NEWPART participants are not conscious. Further, medications for pain and anxiety are administered as part of routine end-of-life care. Finally, should a participant appear to be uncomfortable, the procedure would be stopped. Thus, we believe risks associated with non-therapeutic procedures in the NEWPART study have been minimized and are consistent with minimal risk. Our ethical framework also asks, will valid informed consent be obtained from surrogates? The intensive care unit is a challenging environment to seek consent for research participation. Families may be sleep deprived, overwhelmed with information, and experiencing anticipatory grief. In the NEWPART study, researchers confer with nursing staff and inquire as to whether they think it appropriate to approach a family for consent. Another challenge to informed consent is posed by therapeutic misconception, and it occurs when non-therapeutic research procedures are wrongly thought to benefit the patient. So to mitigate therapeutic misconception, we only approach families after decisions regarding withdrawal of life-sustaining measures and organ donation have been made. And furthermore, the family is approached by a researcher who is not a member of the clinical or organ donation teams. Finally, our ethical framework asks what additional steps are in place to protect the families of research participants. Studies may impact individuals who are not research participants, and these bystanders must be entitled to protection. Research should minimize the impact of changes to end-of-life processes which could adversely affect families. In our study, participants' families are encouraged to remain at the bedside as the research is conducted. There are no restrictions on their freedom to interact with the patient or clinical staff. Families may find the presence of additional monitors, probes, and leads, well, confronting. And to prepare them, family are shown images of the study monitoring devices and their placement during the consent process. Finally, it's important to remember that family members may perceive study involvement as a benefit. The fact that a patient contributes to science in their final moments may imbue the death with an enhanced significance. Thank you for the opportunity to share the work of the Newpart team, and I look forward to your questions.
Thank you so much, Charles. I think Lori, do you wanted to introduce the next speaker?
Yes, our next speaker is Everad Tilokee from Canadian Blood Services. He's a heart transplant recipient himself, and he's going to speak to us about these experiences from a patient's perspective around donor research involving transplant recipients. So Everad, please go ahead.
Hi everyone. Can you all hear me and see me?
We can hear you.
We can hear you, but we can't see you. Can you turn your camera on?
Yep. One sec here.
Okay,
Okay,
thank you very much.
there we go. All right, so thank you for the introduction. It's a pleasure to be here and to talk to you about my perspective around donor research involving transplant recipients. I thought today first I would start with a land acknowledgement. So this is a picture I took from behind my home. I'm based in Ottawa, and I'd just really like to start today with an acknowledgement of the traditional territory upon which I live. I'm based in Ottawa, which is situated on the traditional unceded territory of the Algonquin and Anishinaabe people. And acknowledging this territory is just one way of showing recognition and respect for the First Peoples of Canada, and it's just one element that we have towards cultivating a strong relationship with them. And I think this is becoming increasingly important as we, in light of recent events, and it's something that we're trying to do as a country to reconcile with not just our past, but also our present. And so before I go any further, I did want to disclose that I am employed by Canadian Blood Services, and I also sit on the board of directors at my local cardiac center's Patient Alumni Association. But that's all just to say that today the views that I'm expressing are my own, and that just because I'm a transplant recipient doesn't necessarily give me the right to speak on behalf of all of them. So learning objectives for today. By the end of this talk, I hope everybody comes away with a solid understanding of interventional donor research and also why recipients are needed to actually conduct this type of work. And I'm going to hopefully get through to you the facilitators and the barriers of recipients taking part in this research. Building upon a little bit what Maureen was saying earlier, what we've seen historically with ODT research is that there's been a predominant focus on interventions that are performed on the recipient. So whether that's improved surgical techniques, advanced immunosuppression, better diagnostics or prophylaxis, those are the sorts of things that have traditionally dominated the ODT research space. But it does beg the question then of what about the donors? And so, as Maureen was saying, there are interventions now that are being performed on the donor side of the ODT spectrum. And so this slide isn't any sort of scientific analysis by any means, but it's a screenshot I took from the Trillium Gift of Life Network's website, and it's outlining their current research by focus. And what I did was I put in some red arrows just highlighting a few of these focuses that are looking at interventions performed on the donor. And so, again, we're starting to see a bit of a shift in the focus of research to include more research on the donor side. So specifically, interventional donor research, as I understand it, is research that looks at interventions to improve organ quality that are performed either while the organ is still within the donor or after it's been recovered, but before it's been transplanted into the recipient. So a few examples really quickly, there's critical care / donor management protocols. So similar to what Maureen was saying with that administration of IV heparin. Another example would be putting a donor into a hypothermic state. There's also the surgical techniques of actually recovering the organ that can be studied as well. And then you may have heard about some of these new techniques or devices to preserve the organs during transport. And so here I have a picture of Dr. Darren Freed at the University of Alberta. He's talking about a medical device here that preserves lungs in transport. So that would increase the time that you can have an organ in transport, for example. So what are some of the reasons why a recipient would want to take part in some of this work? Well, first and foremost, if you're on the list, this could potentially increase the likelihood that you're going to get an organ. Further to that, you may also have a better outcome than a standard organ because of that intervention that's been performed. On top of that, there's also the increased likelihood that somebody else receives an organ. By accepting a research organ, you are essentially increasing the pool of available organs. And so you may get an organ and somebody else who is on the wait list might get an organ now that you've accepted that research one. Marginal organs that may have been discarded without any sort of intervention may actually be usable. And so this actually presents an opportunity for us to better honor the donor and their full intentions. And so there's also an element of benevolence. You know, as somebody on the wait list, you've probably been supported by the medical community for years. And so being able to contribute back to that same community by taking part in this research is just one way that you can kind of give back to the community that supported you. And so that's something that does weigh on me as a recipient. And lastly, I think there's an element of gratitude. You know, getting an organ is the most precious gift that you can receive, and it's very difficult sometimes to actually really express the level of gratitude that you feel. And so taking part in this kind of research, again, is one way that we can actually express that gratitude. But I think what's important is it doesn't go to the extent where you feel obligated to give back in that sense. So there are some barriers, of course, to taking part in this kind of research. Some of them apply to not just interventional donor research, but all research. So there's logistical barriers, you know, do I have the time to take part in this study? Will it affect my employment? Where is the study taking place? For some, there may be an emotional burden. Again, if you're a recipient, you've been in the hospital for quite some time, a lot of the time, and not in the best of circumstances. And so, you know, if you have to go back to a study site to do additional imaging, let's say for a study, you know, if going back to the hospital for some may actually be a bit of an emotional burden. And so the last sort of theme that I've identified as a barrier is the one that I think we're going to try and focus on a little bit here is the ethical aspects of this. You know, as a recipient or a prospective recipient, am I capable of giving valid consent? I think Maureen was really good at delineating some of the challenges there, including what am I actually consenting to? With research, it's not always clear, you know, what the actual benefits and risks are. You know, I may have a better outcome from receiving a research organ, but I may not. And likewise, the risks may be higher than we know or less than we know. So it's kind of difficult to really have an informed understanding sometimes of what those risks and benefits are. And another thing that I do think about with this specific context of interventional donor research is, has the donor or surrogate decision maker consented to this research study? And I think that's very important, and I think that's what Charles was focusing on a lot. So I thought I'd go in a little bit more just about some of the questions that I as a recipient think about if I were to participate in this type of research. And the first bullet here sort of relates to what Maureen was talking about with the timing of the consent and breaking it up into multiple steps. So the first question I asked myself was, what am I consenting to receiving a research organ and participating in a trial? Or is it separate entities that require separate consents? And so I personally really liked the synergies sort of strategy of breaking it up into a clinical and research consent, because I think it does address a lot of the big issues about consenting to this type of research. Some other questions that I thought about were, if a standard organ were to become available to me, would I be able to accept that organ before a research organ? Another question was, am I better off waiting for a standard organ over a research organ? And this is very difficult because it's very contextual to the patient, like it's very patient specific. And even within that, the context of a single patient, the answer might change with time. You know, if I am 7 feet tall, have a rare blood type, and have lots of antibodies that make me highly sensitized to receive an organ, I may not have a lot of time to wait for a standard organ. But if I'm somebody of like my height, 5'9", normal weight and okay blood type, I may be able to have the luxury of waiting a bit longer for a standard organ. And so maybe the discussion is very different. And lastly, I thought about what information will be available to the researchers when they're conducting this study post-transplant. I think generally what I'm trying to capture in these questions is that there is a balance that needs to be struck between our want to take part in this very important research, but also in ensuring that we are protected both medically and ethically. And so maybe part of that it comes down to what information, what say we have in the information that's available to researchers. So those are just some of the overall remarks I have about patients taking part in interventional donor research. I just thought I would end on a bit of a personal note and show you an image of my original heart. And really it's just to show you all why this research matters, why the work that you all do matters. This is, again, my old heart. It gave me 24 amazing years of life. It was about 2.5 times the size of a normal human heart. And I'm just over 7 years post-transplant now. And so I have 7 years and counting. And here's just a quick snapshot of some of those 7 years. And again, I'd just like to thank everybody who plays a role in the ODT system. I wouldn't be here without you. And I look forward to discussing this topic further.
That's great. That's very interesting, and it's terrific to see, as always, these pictures of the success at the end of the ultimate success of all these efforts. Mel, I just note that, thank you, Everard, and thanks to the other speakers. I note there are a few questions in the Q&A. And one, if I could just start with the first one that goes back to Maureen, I think, from Sylvie LeMay, and that had to do with, just to understand, if one potential recipient says no to any of the organs that might come, let me see if I get this right, it says no to the organs that might come from a synergy donor, then the donor isn't randomized, so none of the recipients of any of the organs from that one donor would be, Sylvie, let me know if I posed that correctly.
I've heard this question many times, so I think I know. what the question is. And the fact is that if a donor is going to support 4 transplants, if just one of those transplant recipients declines to receive a synergy study organ, if you will, then that donor is not randomized. So they will all receive an organ, but none of them will receive a study organ. And yeah, that it's an issue, and it's a bit contentious, but I think we're taking a conservative approach for our very first study launch.
Yeah, it just really illustrates the complexity of it, doesn't it? Because then that recipient, potential recipient, is making a decision that has an impact on all the others as well, which is really interesting.
Any other comments from the other panelists around that question? No, maybe we can change gear to another question. Laurie, do you have one in mind? If not, I can jump.
Let's see. There was another one on. Well, actually, another one from Suvi. The EEG 1020 system or process. There were some specific questions, I think, from Suvi to the new part team about specific aspects of the EEG, raw waveforms or the process numerical value. I wonder if these, using a cardiac metaphor, asystole doesn't equals the cessation of function, but does not mean reversibility. Do you have any thoughts about the EEG specifically, or not? It's not really thoughts here. It's actual information. The processed EEG waveforms or numerical value or so on, and how will you publish those? I think for you, Charles.
Thanks very much for that question. I should make clear here that I am just a bioethicist and not a neurologist. However, surprisingly, I can partially answer one of those questions, and no one is more surprised at that than me. I can say the EEG is a 1020 system, video EEG, and I'd be happy to provide or line you up with further details. If you just send me an email, Tennille Gofton would be the person to answer the rest of your question. So thank you.
Great. Yeah, I think those details could be worked out. Mel, do you see some other questions in the chat box?
Yes, there's a question. In the case of DCD, when the decision to withdraw treatment is made, are the physician overseeing this blinded to the patient status as a donor? I assume this would be hard to do given the need of a quick turnaround in terms of observing then harvesting organs. I see Charles nodding.
Yeah, I mean, again, I'd love to hear what Maureen's thoughts on this. My impression is that the clinical team is not blinded to the patient's organ donation status. You know, I mean, it would be obvious, I think, from the workup that's being done and so on. There are standard protocols for end of life care of patients who have had life sustaining measures withdrawn. So the idea is that those standard protocols should be followed for patients regardless of their organ donor status.
Thanks,
Maureen, I'm
Charles.
sure you have a much more informed opinion about that question than me.
Well, I wasn't sure I really understood the question, but if they're asking if the physicians are blinded to a study treatment, they very well might be. So if it's a simple treatment like 2 different doses of heparin, there's no reason why the treating clinicians need to know what dose is being applied. But you know, not all interventions could be blinded, and certainly, you know, they would, if the question was more, is this a donor or not at the end of life, who's in the new part study, they would always know if the patient was a donor or not.
Mhm.
And the question from Chilpa, patient, actually, it's not a question, she says, more of a comment, but maybe you can comment on her comment. The process of how and timing when a patient recipient is approached to participate in the research study or receive a research organ can also potentially make a difference, right? You have any comments on that?
I think you did talk about that a little bit, Maureen, on the timing in relation to the transplant, for example, and what you can do ahead of time, but what you maybe can't do because it brings in aspects of potential coercion and so on. Do you want to talk a little bit more about that?
Yeah, I'm sorry, I guess it was my connection. I couldn't really hear everything that Mel was saying, but yeah, I don't think I can comment because I didn't really get the question.
So sorry, I'll repeat. Do you hear me well?
Yeah, I'll turn up my volume. I don't hear you so well.
Okay. So it's more the impact of the timing on when a patient recipient is approached to participate in a research study, how it could make a difference. Yeah, that's a comment from Chilpa on the patient, on the recipient perspective. When do you get approached to participate?
Yeah, I think, you know, as I said, ideally, we would be approaching recipients well in advance of when they receive the notice that there might be an organ available to them, because then they're in a usual state of mind. They have time to process the information, to bounce ideas off people very close to them, and really make an informed decision that isn't rushed or you know, it's comfortable. And I think that is most comfortable for all of us. And I think that we would be more likely to receive a higher rate of consent if we do it in that manner. And it's just unfortunate that we can't always do that. There are a number of studies in the transplant community where they do consent people up front, but in donor, like in the transplant clinics, but with donor research, even with donor research, that could be feasible. But if, you know, just 1 in 100 people, for instance, who have that research discussion are ever going to be offered a study organ, then there are huge resource implications and feasibility issues.
I was wondering if I could follow up on that.
Sure, go ahead.
So I think it's, Maureen, you explained really well the sort of logistical challenges of consent here, the timing challenges and so on. And I think you made a compelling case that it would be plainly infeasible to approach, you know, sort of everyone across 28 centers who's on a transplant list for a full and formal consent process. But I wonder, you know, I wonder if people might not receive, you know, sort of information in sort of batches, and whether there might be a possibility, for instance, to notify, for instance, everyone on the transplant list, say via a letter or a pamphlet or a website, about the existence of the Synergy study, just to provide sort of a broadcast notification across the list, and whether that might help at least promote awareness of the study, so that when people are approached, you know, specifically and told of the existence of the study, that, you know, they'll have had the opportunity to learn about it.
Well, that you raised something, a really excellent suggestion. So we had thought of providing people information up front, and at first thought, well, we can't do that because we can't know everybody who's waitlisted for privacy reasons.
Right.
But transplant programs could, but then they might not be able to speak to the study so much. But if they provide the information, and we provide the website, and then people can connect with us about it. That's an interesting proposition, to be sure.
Yeah.
Thank you.
While we're talking, can I ask a quick question about the next step in the consent process? I promise I won't dominate the question period at all here. It's a very quick question. When you said that when an organ had come up for someone on the transplant list, that they were approached and they would give clinical consent. I was curious what you meant by that. I mean, did you mean sort of verbal consent to receive an organ that had been intervened on in the study?
It needn't be verbal. In fact, we would get a signature somewhere along the way, but this is a consent. I called it clinical because it's just like they might say, oh, I don't want an organ from somebody with Hep C. I don't want an organ from somebody in a study. And that's just a clinical decision. Whereas, and that, as a matter of fact, the discussion around decisions like that is less directive than the research consent discussion and these long research consent forms and the structure and all of that.
Yeah, I guess I would understand what you're doing there as a verbal research consent to receive basically the study intervention. I think sometimes we equate research consent with that horrible 30-page consent form that sort of does nobody any good, right? And I think here, I would describe what you're doing as adapting to challenging circumstances and getting a verbal consent where the person has an opportunity to briefly be informed about and accept or decline the study intervention, namely an organ that's being intervened on. I mean, do you think, is that a fair description of what's going on?
I see your point. Like they are agreeing to receive an organ that's received a treatment, but then the participation in research is another issue, like the sharing of data, perhaps a phone call at 12 months about graft survival and stuff like that. But I do see your point, like you could consider that a research consent as well. And maybe that's not the best terminology that I could use to describe that.
Yeah, it is pretty interesting because you're accepting the intervened upon, if you like, organ. So you're already participating in a research aspect of a process. So to then have to have a separate, I don't know. I'm sure you've thought about it, and it's always complicated, but it does seem to add another layer of complexity to it. Couldn't you include that at the time that you offer the organ that's been intervened on? We have a few more questions here. There are, but can I just ask Charles a question before I read some more of these? What is there any consideration of including pediatric patients in the new part study? I mean,
no, all of the patients are adults.
And do you want to comment on the ethics of including children in organ donation studies?
Yeah, I think there are there are special concerns that arise with the inclusion of children in research, and there are vulnerabilities that come with that, and I think sensitivities as well in the community. So I think a similar study involving children would raise its own issues. I mean, in the study as we're conducting it with adults, I mean, these adults themselves are a vulnerable group, as I explained, and are incapable of consent and so on. And so what I tried to do was lay out sort of the protections that need to be in place for this population. One would need, if one were to do a study with children, and we're not planning on doing that, one would need to lay out a similarly extensive set of protections.
Yeah, I think it is quite similar. And you also have very motivated parents of children who are dying, who want very much for their child to have the opportunity to participate in the act of organ donation as well, just as you do in adults. So it's something that I think as these studies move forward, we should not forget and should not, they are complex, but doing any kind of research in children has another layer of complexity, but you've nicely positioned it that there are surrogates. We deal with that all the time with children, and all of these patients are in vulnerable positions anyway. Mel, did you want to pull another? We have a few more questions in here.
Yes, we have more questions. I have one. Can I ask one question? Everett, you know, what is the importance of the clinical team in taking that decision to receive from your perspective, on receiving a study organ or not? How do you see that discussion going and the importance of that conversation in your consent?
Yeah, it's a good question. The way I view any sort of discussions with a clinical team as a patient is that the clinical team is there as a guide. I still have the autonomy to make the decision, but they're giving me as much information as I can have to make the most informed decision. And so I think what needs to be made clear is obviously, like with any sort of consent, the risks and benefits of participating, but also, you know, the actual, personally, I like to know the ins and outs of the actual protocol of the study. I have a science background, so I like to know as many details. So when I say that, though, there are patients out there that they just need to know the bare minimum about risks and benefits. They don't need to know all the little intricacies of you're going to be called 12 months later after your transplant and then 2 years after. So I think it's a little fluid of a discussion, and I think there needs to be, if you're the person obtaining consent, like the clinical team, you need to try and have an understanding of where maybe the background of the patient. You know, if they're like me and have a bit more of a science background, they might want to know more. Whereas somebody who doesn't have that background might not need to know that nitty-gritty, those granular details. So yeah, I think it's just always about sort of the clinical team is the guide, and ultimately the patient is the one that makes the decision.
And I hear being able to adapt to the need of the patient and their question. Excellent. Laurie, you want to follow up with some question from the chat?
Yeah, there was Sandra Holdsworth has her hand up. Sandra, go ahead.
I'm sorry, do we want to give Sandra speaking permissions?
Yes, please go ahead, Mike.
All right, Sandra, the floor is yours.
I was hoping Laurie about to say no or yes, I'm thinking. Yeah, it's weird. I haven't been able to chat or talk. Anyway, quickly, because a lot of things have been said, but I am the patient partner on the Synergy research that Maureen and Frederick is doing. So I've read through all of it and everything. One thing that I wanted to add is, like, we can do the posters and we can know when to do consent and at what time. But I think that what we need to do, and people that are in research, and, you know, maybe it's the CDTRP thing, or anyone who has a hospital that is known for its research, that we should have, and I don't know what type of person, an assistant or whatever, or even a patient partner, there should be the stage set. Like, so I look at Toronto General there where I had my transplant. I used to go there and we used to wait to go into clinic, right? And so you would talk, but it wasn't unusual to see different people coming around. So I think what we need is someone that goes around and sort of just lets people know that they're part of a research team here at the hospital, and there's all kinds of different research that's going on. And also for their doctor to let them know that, you know, there's lots of different opportunities that you'll have. And in the case for this project, I think that it should be mentioned at the time the patient is listed. Like, you know, there is this research that's going on. I know patients can't give consent ahead of time, but at least setting the stage and letting patients know that that is a possibility, I think could help. And also too, for letting them know that the long-term benefit is for not only for themselves, but other recipients as well. So I think that's where you need to use your patient partners, sort of like the Transplant Ambassador Program does by going into dialysis units and sort of saying, hey, you know, I've had a kidney transplant, you know, you'll be there sometime and whatever. It would be the same thing as like, hey, I'm involved in research and it's so cool. And they've done all these studies and they found this out. And now did you know that they're, you know, putting machines in these lungs in these machines and they're so wonderful and that kind of thing. So you need like a cheerleader that's in there and letting people know is the one point I wanted to make. And since we're talking about ethics, I wanted to ask, I guess, Charles, is this something that we can do ethically? Like, is the right thing to do? And are hospitals allowed to do that? Thanks.
Charles?
So I think it's, you know, I think it's really important actually for, you know, hospitals and other locations where research is going on, to be really open with patients, families, and the surrounding community about the existence of ongoing research. From my perspective, that transparency is all about preserving the trust of patients, families, and the community. And if we don't have that, it's going to be very difficult to do any research at all. So I like very much the idea of perhaps putting more investment into informing patients and families about the existence of ongoing research. You know, we've heard here about how there are special challenges with transplantation research just because of the time frame in which things unfold. And I think it could be you know, truly beneficial to inform patients and families about studies that they may encounter at some point in their journey. So it's an excellent suggestion.
Well, you know, and there are lots of ways of getting it out there that I've seen in, you know, in social media and in just all kinds of websites related to the home base of a study or the CDTRP home base or something like that, where it says, are you interested in this? We have these 5 studies up, or would you be interested? Here's who to contact. And, you know, just from seeing some of the work done in the vaccine, the COVID vaccine stuff, boy, that, I mean, those things go far and wide and fast. And they really, I think if they're done well, can really be informative to patients and families about opportunities to participate in research. We have an interesting question from Dave Hartel here. Given variability in end-of-life care practices across centers and post-transplant care, so the variability of all that, how confident are we that we can attribute a therapeutic intervention in the donor with specific outcomes in the recipient? And what level of evidence do we need to change practice? I could go, I guess, to Maureen, perhaps to start, and then maybe to Charles.
Sure. Well, if it's a donor intervention, then really, you know, the gold standard would be a randomized clinical trial, and because then there's so many things that differ from one donor to the next, from one recipient to the next, that can confound graft function or graft longevity and recipient well-being. But if we research this in the context of randomized clinical trials, then, and large ones like we would do across Canada, then we can feel quite confident that all of those confounders will be pretty evenly distributed between the two study groups. And we can collect that data and ensure that that happens as well. And so then that provides a very high level of evidence that something is helpful.
Thanks, Maureen.
And I should add that I think we have to remember that some of the research is really directed at one type of organ transplant, but we always need to be cognizant that there might be effects in the other transplant recipients from a multi-organ donor. And we may think or anticipate that there will be none, but unless we're looking for them, we might not find some that exist.
Do you think it's important to look at sex and gender differences in these kinds of studies?
I do. I mean, there are some differences between sexes in the rate of donation and the receipt of transplants, and then probably I don't know enough about this, but in transplant medicine, the anti-rejection drugs and other medications might have differential effects between the sexes. And so some of our donor interventions may as well. So I think it is important to consider.
I would agree. And probably both sex as a biologic variable and gender as a social construct are both going to be important in different ways in this kind of research, I think. Mel, I noticed there's a question in French in the Q&A.
So in the context where the organ is, you know, it's a rare, you know, it's a gift when you receive the call. Would a recipient be penalized not to what's the impact of refusal of the treated organ? That was the question. But I think you addressed that a bit in your presentation, that the person, at least in Synergy study, if you refuse, you're still going to get an organ, right? What's the impact of the refusal?
I see. So if the recipient refuses the organ, then they still, refuses the study organ, they still get the organ and the other recipients get the organ, but the donor is not in the study. If at the second stage they decline to engage in the data collection or provision of data, it's actually quite a passive role because other people are collecting the data from the records. But if they decline that, that has no bearing on the care that they'll receive from the transplant program. In fact, the people that are collecting the consent from these transplant recipients are from our critical care research network. And they're in these, the critical care units are in transplant centers. And so it's our network from the donation side that the individuals will go out and solicit this research consent, and the transplant community, they won't mind either way. They don't even need to know if the recipient is participating in the data part.